Good afternoon. Welcome to Grand Rounds today. Today I have the pleasure of introducing Dr. Ikigu Thuku. Dr. Thuku is a physical medicine and rehabilitation specialist and also a pain medicine specialist. He did his PM&R residency at Virginia Commonwealth, and he stayed there to do his pain medicine fellowship. He's been a member of the medical staff at MGMC since 2018, and we're very appreciative of his acceptance of our invitation today to speak on pain and in particular low back pain. And please join me in welcoming Dr. Thuku. Thank you.
Thank you so much, Dr. Holberg. Appreciate your introduction. Actually, also to the people behind this presentation, because I'm doing this from Marshalltown. So thank you, Tim and Sally. So today we are going to the second part of our common pain disorders. I did the first one like a couple of years ago, and today we will mostly talk about lower back pain. And when I was thinking about how to do this presentation, it's obviously a large topics, and actually some of the sections in here can be large topics on their own. So I try to mostly keep it brief, provide highlights. Also go into some details here and there. The other thing to note is there can also be many different ways of approaching this topic. And I think when you see presentation on this, people do it in several ways. But I chose to approach it this way so that I can drive a couple of points home by the end of the presentation. I do not have any disclosures. For the outline of our presentations today, we'll start with, how people define what is lower back and what is lower back pain. Then we'll talk about some factors and causes. We'll use a couple of different approaches to those. Then we'll talk about how to evaluate a patient with lower back pain. We'll talk about imaging, treatment, and then I have take home points. So who sees or who treats lower back pain? The four in here are actually kind of the first line of defense. And I would say that most of the patients that I have seen have at least been treated by either one of these primary care providers, the most popular. Also in Iowa, chiropractors have their good share. And then internists do get some admissions from the ED for lower back pain. And I've definitely seen some patients, inpatients for this. And then massage therapists, they usually see patients right out of work or when they feel like, when patients feel like they have tight muscles. Now, for the specialists, there are a few of them that see pain, physiatrists, neurologists, pain medicine, also psychologists. We do have specific pain psychologists. They are rare to find in Iowa. And then definitely the surgeons. Myself, I'm a physiatrist. I actually do not need a pain fellowship to deal with pain as a physiatrist. By the way, for those people who are not familiar with physiatry or a physiatrist, it's somebody who practices in physical medicine and rehab, which is like midway or in between neurology and orthopedics. And it's a big difference from a psychiatrist. So make sure, some people do confuse both of them, physiatry versus psychiatry. For physiatry, we do see a lot of pain, especially because of the diagnosis that we deal with. So patients with spinal cord injuries usually have a lot of pain, TBI patients. Also, we do deal with joint pains a lot. Well, by the end of this presentation, I'm hoping we can talk about how to escalate care for patients, and we can see when to refer them to the specialists, as including the surgeons. So our first part is how to define lower back, as well as the epidemiology of how common this is. The lower back area, anatomically, it's definitely the bottom of from the bottom of your rib cage to just above the buttocks, or just above what patients call most of the time hips, which is really sometimes confusing for providers, because hips, we tend to think of the anterior hip instead of the posterior part. But lower back is that place between your rib cage and the bottom of your buttocks. And sometimes the pain can radiate down the legs. And still, I do have patients who call it lower back pain. So next here, I have actually pictures from my patients that I actually saw last week. And I do like the pictures a lot because they can give you insight into what the patient thinks about their pain. You can see the first one is just a line, then the other one is radiating down the left, or actually the right leg. Then the other one, they have this pain across the lower back into the buttocks and bilateral posterior thighs. The third one has this good radicular pain down the left lower extremity, mostly posteriorly. The fifth one, we all have one of those where they have pain mostly everywhere. But it's interesting for her, she did not have pain across her buttocks. So that's why I say that these pictures do help a lot, not only in trying to figure out what's causing the pain and how to treat it, but also it helps you to be able to figure out what the patient is thinking about their pain. And that can help you a lot in knowing how to create a relationship, as well as how to approach or how to recommend treatment. Then how common is back pain? I mean, I believe every one of us here or who is listening to this has had some back pain at some point in their life, whether it's you sleep wrong, or it's from a fall, or whether it's also when you're lifting something. It's very common to have that. The one thing that is also frustrating, but I guess it's also, with something that is so common, is the data is not consistent at all. For example, when you look at this, the figure for recurrence lower back pain annually, it's a wide range. It goes from 24 to 80%. And actually, the paper that I could find here was the one which was trying to have minimal ranges. So the incidence also is pretty wide, from 1.5 to 36%. And then definitely the Academy for Family Physicians, they usually say this is the fifth most common reason for physicians visit. And that is not surprising, that when they looked at the global burden of the disease, and this was back in 2010, it's ranked very high in terms of the disability. It also was the number one cause for Americans younger than 45 years of age. I know people might disagree on the metrics of how the global burden came about, but it's pretty clear from even our everyday experiences how common this is, and how common it is for people to miss work due to back pain. And that leads us to the risk factors for this. The biggest risk factors that I could have come across from several papers was one, low education status. And I think that's mostly because people with low education status tend to do more physical jobs. And I feel more physical jobs will definitely expose you to back pain and other musculoskeletal problems. Then the other thing that I actually pay close attention to is stress. So the minute that I see the patient, I'm always looking at their mood. Are they happy? Are they sad? I know they're in pain, but there is a different vibe, or there's a different feeling that you get from a patient when they are depressed or when they are pretty stressed. And actually, the stress can come from family. It can also come from the job. And I think this is where the global burden actually is more evident is with job dissatisfactions and the losses, the economic losses from the lower back pain from patients missing their work. Then whole body vibration is something that I kept saying over and over again, that it can be a pretty significant risk factor for lower back pain. Not surprising, obesity and smoking are also there. More risk factors, we do have trauma, but actually I think trauma for some of the patients is they already have arthritis in their back, and once they either fall or they try to lift something, it immediately exacerbates the symptoms. And sometimes patients will feel like this was what caused my back pain, but unfortunately they might have had a disc bulge that just got worse because they had the injury. So it's usually hard to determine the exact cause of this because some of the lower back pain is just as a result of degenerative changes. Then definitely lack of exercises, which leads to weak muscles, also can lead to tense muscles. We know for sure exercises will help prevent a lot of medical problems, and back pain is a part of it. It can actually, exercise can actually help relieve some of these symptoms, especially when people do stretching after the exercises or some yoga. That does come in handy with preventing back pain issues. For exercises with back pain, it just strengthens the muscles, and the muscles can support the joints and discs better. Well, there's also genetic predispositions and changes in the central nervous system, but that tends to happen a lot over time, especially with chronic pain. The other way to look at the causes is sometimes they're not easy to determine, and this is where I look at two aspects of it. It's the event that led to the symptoms or the pathology. Sometimes it's just hard to tell what exact cause in those two areas. First of all, patients just have problems remembering the event, or sometimes they'll say, I was just sitting on the couch and I just had this severe pain going down my leg. Then you also run into problems with causes because some patients want to really find out what caused my pain. They feel like we have been treating my pain, but we don't know what caused it. And sometimes I have to try to bring patients back to the treatment part of it when they dwell too much on the cause. And it can get pretty frustrating trying to do that. But we'll discuss more about this in the upcoming slides. So duration-wise, and I guess this is where we can mention a little bit about the natural history of back pain. So sometimes if patients don't even seek treatment for back pain, their back pain can get better. And this usually tends to happen within the first 6 weeks. So 90% of the patient will get better within that time period. I actually will see some patients who are referred to me, and then by the time they see me, the pain has started to get better, but they said, oh, I just wanted to come to see you, so just in case this comes back, you already know me. So I do have a few patients who come in to see me, even if their pain is better for sure. Then you see clearly with the 3% who do not improve, that's where those are the ones who undergo or who increase the costs due or that are related to the back pain. So they actually are responsible for about 50%. And this is where we go into acute and chronic. Acute is where you have less than 3 months, and chronic is more than 3 months. But also remember, there can be acute on chronic lower back pain, as we have acute on chronic renal failure. So something can happen with the back pain. So the other aspect of how you can classify this is according to the acuteness of the pain. And here, the most common acute lower back pain causes are lumbar strain. You can also have a fracture or an aneurysm. But interestingly, the hardest diagnosis to make is lumbar strain because you don't have an imaging. Unlike the fracture or unlike the aortic aneurysm, you don't have an imaging that would show the strain itself. Even the MRIs, sometimes they can make comments, but it's hard to tell. They're also so interesting, like the treatment for strain is also sometimes very frustrating because the muscle relaxants are not helpful. Sometimes you do trigger points and they do not last long. Then having to talk to patients about their ergonomic changes, it can be pretty frustrating for patients because they want a quick fix. But unfortunately, some of the lumbar strain and muscle issues are not a quick fix. And then you run into the problem whereby patients feel like there's something worse than the muscles that's causing the pain. And now you have to counsel them, you have to educate them about pain because you will say, oh, I need another MRI, I need another CT. So it can be a long haul for the lumbar strain. The aneurysm, we'll talk more about that with the red flags. Then chronic back pain. And this one can be very different for different people. It has a wide spectrum of presentation in terms of duration, severity of symptoms. And now, when you have such a wide spectrum, that also means you might have a wide spectrum in terms of treatment too. And we'll learn into treatment later when we talk about this. So the three ways that are most common for chronic lower back pain to present is whereby you have severe pain, where you have waxing and waning of the symptoms, where you have severe pain changing with milder. That's very common. Then you can have a constant nagging pain that patient will say, oh, it does appear when I do, like when I'm at work for 8 hours, I don't have it at home when I'm relaxing on weekends, or when I walk for 5 miles, then that's when I see it. Just a constant nagging pain, especially when they do activity. Then you have the patients who are in really severe pain and it can last for a long time. And sometimes you try all kind of interventions and they fail. And that's when even escalating care sometimes can be quite frustrating. But we'll get to that later. Now, what causes chronic lower back pain? The mostly that I could find was degenerative changes, and that is with disc disease as well as with some of the joints in the back, and that is your facet joints. We'll see a picture of this later. Also your SI joint bilaterally, and definitely the hip joints. This is also, you have to be aware of systemic diseases too that can cause this pain, and this includes, the autoimmune diseases. So you have to put that at the back of your mind in order to make sure you're covering all the bases. The other way you can look at causes, and I always think about this, whether it's acute, chronic, or whether it's related to stress or what it is a pain radiating or not? Because this would definitely help you zero in even more from the other aspects that you already have. So with non-radiating pain, it can be due to facet arthritis, osteoarthritis. It can also be due to myofascial pain. It can also be due to ankylosing spondylitis or psoriatic spondylitis or osteoporosis. Cancer, like in any other diagnosis, seems to be everywhere for both. These are the causes of radiating pain. And the hallmark for radiating lower back pain is you must have a nerve impingement, whether what patients will refer to mostly as sciatica, but then you have to find out what nerve root it is or where the impingement is. You can also have stenosis, to be multiple levels. Actually, the top three are the most common. So your disc herniation, your SI joint, and spinal stenosis. the SI joint usually tends to go down to the buttocks. If it's really, really severe, it can sometimes radiate to posterior knee, but it usually doesn't go below the knee. Piriformis syndrome is common, and of course, you have your rare ones, the infection. Well, actually, now we're gonna go fast to evaluating the patient before we talk more about radiating pain and how to treat it. And when I see any patient, whether it's lower back, neck pain, or spinal cord or anything, the first thing I do is I see the patient, I actually don't even start by talking to them. I'm actually lucky because right now where I am in my office, I can see the patient come in and patient leave. And I consider that part of my visit because it can give me a lot of information. And the reason why I said nonverbal is because you actually, and most of the time, we see the patients before we talk to them. And I guess also we've been able to prove over and over again that light travels faster than sound. And I mean, I do all this for all my patients, regardless of why they are there to see me. The one thing that I like about just seeing the patient, whether it's in the hallway or whether they're walking into the building or whether it's in the room when I open the door first, is because it helps me kind of tell where to begin and even how to create a rapport with the patient. Because if I see that, they have a Vikings t-shirt who I don't like, or if they have a Chiefs, then we can, or, something that they are wearing, some good shoes, then it kind of helps me to be able to create a relationship with that patient. And it can actually help more into being able to know how to approach a patient when you talk to them about treatment. So that's key. Inspecting and seeing patients is key. Then we go to the first part of the history of present illness. And usually I ask all or most of these questions the first time I see the patients. There are about 9 to 10 of them. And you see them, different providers use them differently. There are different ways of getting this information here. But the ones that I pay attention to is the aggravating factors and relieving factors. And then they are supported by the rest of the group. So I actually have to make sure I ask those two for every visit, whether it's an initial evaluation or whether it's a follow-up. Something else that I also find very helpful with the history is when I talk to them about their previous treatment. I always make sure this is a part of my evaluation. Have you done physical therapy? How did physical therapy go? What kind of exercise did they do? Did they help? Did they not? Are you using ice or are you using hot packs? Because this will help you tell whether it's a muscle problem, disc problem, or a bone problem. Did you get a massage? How did that go? Did they help your symptoms? Then also medications are important. They'll say, my physician gave me a Medrodose pack. I felt good. If they gave me gabapentin, it did not make a difference. Or they gave me some Nabumatone, and that helped a lot of my symptoms. So that will help me tell what kind of pain it is. Is it nociceptive? Is it neuropathic? And then exercises, and also especially like yoga and meditation. I actually sometimes will use those two questions to introduce the patient to talking about whether they are stressed or the anxiety or depression. Because sometimes if you go and you ask a patient, are you depressed? They might hesitate because it's always sensitive, and they might actually give you the best answer. So sometimes I go, do you do yoga? What do you think about meditation? Oh, by the way, are you anxious? Are you so, and that kind of eases the patient into the question. So this previous treatment part is a big part of the evaluation when I see the patients. Then you have the usual, and I say the usual because we do it a lot and we do it for most of the medical problems. They are a must to review, and this is because these before can affect your treatment a lot. For example, for back pain, you have to know whether patients have diabetes, whether they're on anticoagulation, also some different kind of pain, like if the patient had a spinal cord injury or a TBI, then you are like, they might have spasticity. So that leads you more into the diagnosis and to appropriately treat the patients. Also, the history will help you get some red flags. And this is where actually cancer is one of the things that you can find out easily from this. And that leads us to talking, just mentioning the red flags for now. So the one thing that I always include in my evaluation is bladder bowel issues, because the incontinence is key in determining sometimes how quickly we need to treat the patient and whether they need to do injections, medication, surgery, what have you. The other ones are fever, long-term steroid use, and IV drug use, because even though they are rare, if you miss those, they can have catastrophic effect as well as the cancer history. Then going into the exam, this goes back to what I talked about, my nonverbal evaluation that I mentioned. Sometimes I actually wait to see the patient leave the room to see how they're walking or to see how they do. And it starts the first time that I see them when they're coming in. Are they being supported? Is there a cane in the room? What are they sitting on? How are they sitting? It just helps me to start formulate the diagnosis or possibly what I need to look further for in the exam. And this one comes in terms of like about 5 different stages or classifications. But again, this also can vary depending on the provider. The one thing that I am constantly looking for, and I mentioned it earlier, is the patient's mood, stress, anxiety. I'm always constantly, even the way they're answering my questions, I'm always constantly looking for any issues with that, because first of all, that will help you formulate or know the next step or how to approach certain conversations that can, again, be sensitive. Like this morning, I had a patient who came into the clinic because of lower back pain, but she had a paper in her hand and I could see she was anxious for answers. And actually, what I asked her first is, I see you have some questions, even though she had not told me she had questions. And I let her ask all the questions even before we started talking. And I was able to address them. She seemed like she had done her research and had some good background, so it was easy to be able to do that. And then it was my turn to ask the questions. And actually from there, the interview went very well because she saw I was willing to answer her questions. And she was also, now she had to reiterate and answer my questions. So I actually, that encounter ended up going very well because she seemed to relax more, that she had some answers to her questions. So the other important part of the exam is inspection. You have to look for scoliosis, whether there's any swellings, is there any joint deformities, spasms, because even though patients are coming with lower back pain, they can have a history of a stroke that affects the right side, and they're having this severe right-sided lower back pain. And sometimes that can be due to spasticity. Also, the other thing is for palpation and percussion. I don't think I can say this enough, is always make sure you start with the less painful side before you go to the more painful side. You definitely get more from your exam by doing that. And again, I'm simplifying this a lot, and I'm putting down, I'm stating mostly the highlights of everything. So there is more details to the exams themselves. Now, usually with my exam, I have a way that I do it, and I just follow these 4 things. I do strength first, reflexes, then I do dermatomes, and then or sensation, and then I do the provocative tests. And I would encourage everyone to make sure whether you're doing a cardiac exam, or a neck exam, or you're doing an abdominal exam, to develop a habit of doing the exam in a certain way to make sure you cover all the bases. And sometimes we forget the simple things. And sometimes those simple things can actually give you a lot of information on what is going on with the patient. Now, when I do the range of movement exam, if there's any problem, then I know this is most likely a bone, nerve, or muscle issue. When there's weakness, I'm thinking, oh, this might be nerves involved, even though the muscles are the ones that are weak. And then with palpation, sometimes it can be due to the arthritis. It can be due to sometimes the trigger points. I can be able to feel that. So it can be either bone, muscle, or joint issue. I also do the reflexes, and if the reflexes are abnormal, then I feel like, oh, these ones are related. There's a nerve issue going on. Is their nerve being compressed or something like that? Same thing with sensation. When you have a dermatome that there's numbness, there's no pinprick, or there's no touch, then it's either an L4 or L5 radiculopathy. So that does help. In talking about the exam, just to review some of the common things to see for scoliosis. Actually, immediately I see the patient, I'm looking at their shoulder height. Is it the same? Is one side? Because that can help me or can lead me to being able to look further for the scoliosis part of it. And this is actually very common, and sometimes it can be missed easily too. And actually now when you have this, it can lead to the other problems. Now I know with somebody who has scoliosis, they most likely will have some facet arthropathy, or they will most likely have some stenosis just because of the curvature. Now, the next thing is with the facet arthritis that we just mentioned with scoliosis. These ones you mostly have to do some range of movement, and also you have to do some palpation. So for the lower back, you feel for the spinous process, and then you just palpate just laterally to the spinous processes. You can also do what we call facet loading. This is where you ask the patient to rotate their back, and then you extend it. I don't recommend extending the patient if they already have severe pain with rotation, because sometimes that can cause even more severe pain. The other interesting thing with the facet arthropathy, which can be confusing, is the pain can go actually to the anterior thigh. I have a lot of patients who come to me and they say, oh, I have this pain in my groin and anterior thigh, and I have numbness over the area. So that can come from facet. And you have to differentiate that from an L3 or L2 radiculopathy. And I think with the exam, it can give you a lot of that information. Now, the other part that can cause a lot of pain is the SI joint. This is one of the hardest ones to diagnose. And this is despite the multiple provocative tests that that are out there for SI joints. And this is because they all have low specificity and sensitivity. And they also vary according to the examiner. You have also some patients who are just hard to evaluate with that certain provocative tests just because of the body habitus. So I actually sometimes, if I have, and they have tenderness and they have 2 or 3 positive provocative tests, I actually sometimes I'm not sure whether this is still the SI, and I'll decide, I might have to do a diagnostic joint injection to see whether their pain goes away. And sometimes it will, sometimes it's not. So it's not usually an easy diagnosis to make, and it's also actually not easy to treat. It can lead to chronic lower back pain. The other part that can also cause back pain is your piriformis, and this one can actually radiate down the leg. Here, by this one, you test this by flexing and also abducting and internally rotating the hip to see whether you can stretch out the external hip rotators. Sometimes you can be able to palpate it depending on the patient's body habitus. But the one thing before, and I usually recommend this, before we say it's just piriformis, it's always good to rule out disc disease. I do have seen patients who have come with a diagnosis of piriformis, but despite what you do for piriformis treatment, pain continues, and sometimes if you get an MRI, they do have a disc disease. So I have seen that. So sometimes, which actually we're going to discuss it in a couple of slides after this, the disc disease. But before that, hip joints. It's a key part. It's a key part of the exam because it's easy to do, first of all, and also if you miss it, it can be pretty debilitating for the patient. And I've seen this several times, whereby patients do not have their hips tested, and when they come in, it's pretty clear that it's a hip pain just from the range of movement. And actually, sometimes you can even do it. The patient is sitting down. You just hold their thigh, and you externally and internally rotate, and the patient will let you know whether it's the hip or not. So that's always a good thing to check when patient comes with back pain. And then the last thing here, and I did it last because when this is present, it just makes everything else inflamed, whether it's the facet, the SI joints, or the piriformis, and it's the lumbar disc disease. You can see in this picture, there's a good disc herniation, and usually these ones do radiate all the way down to the leg. And this is where also sometimes the patient has SI joint pain, and if they have a disc, I actually treat the disc first because I know this can cause inflammation of the SIs too. Now, the next part of this is the imaging. And here, usually, the recommendations are not to obtain any lower back imaging for the first 4 to 6 weeks. And this is because the pain usually resolves within the first 6 weeks. Now, you have to be careful about the red flags. If the patient has a history of cancer or they have a history of fever, then that changes your management. They might need a CT or an MRI. Also, if they have a history of fall and on exam, they have giveaway or crepitus on palpation, then you're concerned about a fracture, then you have to obtain some imaging. The different forms of imaging, most common, X-ray, CT, myelogram, MRIs. I couldn't find a good source that explained exactly what imaging to get for what, but that will be more on the next slide. Here, we look at the costs. So imaging is a big part of lower back pain costs because we tend to get a lot of imaging, which sometimes is patient-driven or provider-driven. And you can see this is actually from an older paper. And the price, even for the X-ray, can be $200 for the CT. It can go to the thousands. Same thing with the MRIs. But routine imaging definitely does not improve clinical outcomes. You can do all the imaging you want. It's not going to change the back pain. And also we know that some of the findings that you find on the patient, you also on non-asymptomatic patients are the same that sometimes you're going to find in a patient with pain. But this is where the exam comes in handy. And I would encourage everybody, whether it's a chest X-ray or whatever you order, that you always review your images. Because remember, the radiologist has not seen the patient, but you have seen the patient. The other important point is that imaging is never always equal to the symptoms. This is a busy slide, but it just displays some recommendations from the Neurological Society of what kind of imaging to obtain for different patient symptoms. And I think the main ones are with radiculopathy, where you need an MRI. But if patients don't have radicular pain, usually would recommend an MRI. So this is kind of a quick summary of the imaging. So no imaging for the first 6 weeks. The patient does not have any red flags, no radicular pain, then you can just get an X-ray. If they have radicular pain, then an MRI or a CT. If you're concerned about the hip joints, I actually like instead of doing a hip X-ray, I actually like the one that does bilateral hits on the pelvis. It actually gives you more information, not only for your side, but also you have something else to compare to. Well, also imaging is going to depend on the insurance sometimes. If I know a patient needed a CT quick and they have Medicaid, or if I know a patient needs an imaging quick and they have Medicaid, I usually sometimes tend to do the CT instead of an MRI, because sometimes that can take longer for MRI approval. So also watch for the insurance. And then treatment. Here we'll mostly talk about specific diagnosis and see whether that will help us, understand a little bit better how to escalate care. But I think we'll also mostly start by the patient symptoms. But before you even talk about treatment, it's very honorable and it's always a good thing to do. And I wish it was more practical than being just honorable to mention that prevention is key. I mean, this will be the mother of all, but we just don't do it. Whether it's back pain or any other medical problems, I just don't know why we became a curative society, but that's what we are. But what I actually do is when patients come to me with back pain and they get better, I always go back to prevention. And we always talk about what can we do to prevent this pain from coming back. And this is where we talk about exercise, economic changes, weight loss, healthy living style, stress prevention. Yes, I do preach this during my regular, when we are treating them, but this especially I have to make sure before I discharge a patient from my clinic, for those who actually come back, that I'm able to talk to them about prevention for future. So acute lower back pain. Here we have symptoms for less than 3 months. It can be radiating or non-radiating. Is there any red flags? Any bowel, urine, fever? So if there is no red flags, usually can recommend conservative management, and that's ice, heat, medication. You can also, for non-radiating pain, that's mostly like I would recommend NSAIDs and muscle relaxants. Radiating pain, please make sure the patient, if they are not allergic to it or they can tolerate it, they have gabapentin or metrodospac. It's a lot of patients with the lumbar radiculopathy that I see without gabapentin, but actually that I would recommend is as a first line for radiating lower back pain. Then physical therapy and chiropractor. Those are the main things. So for non-radiating lower back pain causes, these ones we talked about before. This was from the previous slide. And that's why I would recommend some of this. Now, when I talk about conservative management, this is what I'm talking about, because I'm going to mention it several times. It's the ice, heat, home exercises, medications, non-radiating. Now, I'm actually also running out of time, so excuse me if I go a little bit faster. I highlighted depression and anxiety because that's a big thing with conservative management, where you need to encourage patients, not just medications-wise or refer to a psychiatry, encourage them to do meditation, yoga, encourage them to talk to family and friends, church members, also talk to them about hobbies too, to see whether it can improve that. Now, treatment, we're going to go more into the specific diagnosis or presentations here, whereby, for example, you have a patient who comes in with neurogenic claudication, they are 50 years of age, they have lower back pain. I can be single or both legs, and pain is increased and going up, downhill than uphill. So this one sounds more like a lumbar spinal stenosis. And usually here we do the conservative management first, which we talked about, and I'll clearly stress that medrolidospac and gabapentin do help. Now, if conservative management and medications fail, the next best thing is to refer a patient to pain. And this is where I have seen some patients go directly to the surgeons, but guess what? The surgeons will refer the patients back to pain to try some injections first. And for stenosis, we can do some steroid injections. And then if the injections fail, then we can definitely refer them to spine surgery. I think the biggest key with stenosis also is to monitor for muscle weakness or any symptoms that, or any bladder or bowel issues, because then that's an indication that most likely surgery will help the patient. Now, the next one here is increased pain with driving, sitting, coughing, sneezing, bowel movement, decreased pain with standing, knees flexed, and then it can be either one leg or both legs. This is most likely lumbar disc disease or radiculopathy. So again, recommend conservative management, medrolidospac, gabapentin. I usually, if the pain is too severe, I do recommend, or there's a recommendation for low dose opioids for patients to use. But that also goes into the big aspect of opioids, and that's another conversation for another day, where you need to make sure the patient is appropriate for this. You have tried other medications and they have not worked. And at the same time, referring patients again to pain instead of surgeons first is the way to go. Same thing like stenosis, watch for muscle weakness, bladder or bowel issues. Now, the other different one from the last two, that is stenosis and radiculopathy, is when you have patient with just pain in the back. They don't have any pain relating to the legs. And this is most likely due to facet arthropathy. This one actually, you do the same thing treatment-wise, but medications usually use the anti-inflammatories. Spine surgery referral usually does not help here because they try to avoid treating actual lower back pain because it has really low success with back surgery. And this is where actually patients can benefit a lot from some of the injections that we do, including facet joints injections. You can do medial branch blocks and radiofrequency ablation. After that, I always recommend exercise for patients to strengthen their back and to stabilize their lumbar. Then the last one here is the SI joint, where patients are having pain in the buttocks, and it can go down to their posterior thighs bilaterally. They have pain with sitting. Sometimes actually the patient can be able to point to the source of the pain. It can be sharp and stabbing in nature. So this one again can do the anti-inflammatories. Usually the neuropathics do not help, or the medrolidospac, no spine surgery referral, and then we can refer to pain for SI joint or radiofrequency ablation. Exercise is key to this. Then you do have the red flags that you have to watch for. We have had cardiac multiple times that requires emergency surgery. Same thing with the abdominal aortic aneurysm, also that requires emergency consults. The one of the rare ones, but I have seen it, and actually just had a patient with this, is fever, night sweats, history of IV drug use, or patient immunocompromised. Watch for epidural abscesses or something like that for them. The other one is a cancer, and then of course it's the kidney stones that do cause lower back pain. Now, the major take-home points here are, if patient has or does not have, if patient does not have radicular pain, sometimes it's okay to refer them to specialists with just the X-ray, or if they have radicular pain, an MRI or a CT is essential, because most likely that will tell what level or what kind of disc disease that they have. Stenosis. If they have hip joint pain, then please make sure that you obtain like some bilateral hip and pelvic X-ray. And the other aspect of it is imaging. If no red flags, you don't have to do that for the first 6 weeks. And then the last take point here is escalation of care. I think the biggest thing with this one is it avoids delays in treatment, and definitely if you avoid delay in treatment, then it can increase patient satisfaction. I actually would encourage all the providers, especially within McFarland, can reach out to me or Dr. Paranto if you have any questions about patients with back pain and what to do next. Also, if you're not within McFarland, please reach out to your specific pain specialist and ask them questions. I don't think I've met a pain specialist who doesn't like to ask questions, and I say that with a smile. Now, the last part is some of these patients, if they fail pain specialist interventions, we can always refer them back to spine surgery. And sometimes actually the patients who go to surgery do come back to us if they still have the pain. So if you have a patient who had gone surgery, they have still pain, please give us a call and we can direct you to the right way. Well, that is it for today. I know this the slides here are not the same as the one that we had before. If anybody wants these current slides, please reach out to Sally. Thank you.